Public sector unions are pressuring the government employees' medical scheme, GEMS, to keep its 2026 contribution increase to single digits after this year's controversial 13.4% hike. The double-digit premium increase was implemented despite opposition from two of the public sector's biggest unions, that is the Public Servants Association, the PSA, as well as the National Education, Health and Allied Workers Union, that is Nehawu. It also came after several years of modest increases. Confirming that unions do not want another double-digit increase, GEMS Principal Officer Stan Moloabi has indicated that the scheme will come up with viable solutions that take the interests of members into consideration while protecting the financial sustainability of the scheme. Members have indicated they would like next year's premium increase to be no higher than medical price inflation, which is likely to be about 8.5% or thereabouts over the year. So let's make sense of it all. I'm joined now by the PSA's Acting Deputy General Manager, Claude Naker, as well as Dr. Stan Moloabi, who is the GEMS Principal Officer. Good afternoon to the both of you. Let me start with you, Claude, just for me and everyone else to understand your call. People would say it's still early days, but I suppose in your cycle of planning and negotiation, it is not early days. What has triggered this call that you are making as public sector unions for increases in contributions to be kept to single digits?
Yes, a very good day to you. Thank you for having me. I think one of the reasons is that while we're making this early call is that increases in medical aid tariffs is not something that's negotiated with the union. It's merely consulted and then it's implemented by GEMS. So we want to get this call in as very early as possible. I think most public servants are still reeling from the fact that 13.4% was increased this year, and then the salary increase was implemented in April. Public servants got a salary increase in the region of 5.5%, as opposed to a 13.4% increase in medical aid. So you can see the disparity that whatever increase that public servants received was simply wiped out by the GEMS increase in tariffs. If you look at last year, they also received in the region of 5%, and the increase was in the region of 9%. Now, we had to take a lot of stick from our members to say, why is medical aid, especially GEMS, increasing at such a rapid rate? When you look at other schemes in the open market, their increases were kept to single digits. When we did an analysis of the other open schemes, we found that most of them, their increases in the last 2 years was far lower than GEMS. So this made us wonder as to what prompted GEMS, beside us severely calling for a single digit to keep it low, perhaps in line with inflation. But this obviously did not materialize, and we had to take a lot of stick from members to say that we need to engage with GEMS as early as possible so that they can keep the tariffs as low as possible.
Dr. Moloabi?
So you will... Yeah.
Sorry, Claude. I think you're finishing a point. Please go ahead. Yeah.
No, I just want to say that another analysis is that just 16% of the population, which is inclusive of public servants, actually are on medical aids. In other words, they have some sort of medical aid cover. This gives you the analysis that medical aid is no longer something that's a necessity. It's something that's a privilege, simply because it has become unaffordable, especially for those in the public sector. Yeah. When we signed this agreement, one of the tenets or one of the cornerstones of signing this agreement that public servants not only will receive proper health care, but affordable medical aid. And that obviously is aspiring towards a situation where we find members that are either opting to go down to a lower scheme simply because they cannot afford it, or alternatively, if that is not financially viable, they're actually opting out of medical aid. Now, that's going to pose a problem for us. Yeah. Sooner or later, we're going to have a scheme that's simply not going to be sustainable, simply because of the increases.
Dr. Moloabi, doesn't sound unreasonable, at least to an outsider like me, not familiar with the workings of how you arrive at these determinations of the increases. But what they're saying, what the PSA and others are saying, doesn't sound that unreasonable. 13.4% was the increase for this year, and we anticipate that medical price inflation will hover around 8.5%. What do you make of the call that you should keep any increases for 2026 to single digits only?
No, thanks a lot to Lassis, and good afternoon, and good afternoon to Claude as well. It doesn't sound unreasonable what he's saying in terms of a solution going forward. What I would actually like is really Claude and me are supposed to meet soon, because some of the things he said in the preamble we need to talk about, so that the next time when we come on here, we really have to state the actual facts. But be that as it may be, we are all faced with a challenge where we had high increases. That is for 2025. There are 2 years where we had an increase of 2 and 5, and if you average over those past years, it is not as Claude says, but that's not the purpose of our discussion. That we can resolve between ourselves. What I would love to say is that we are working very hard to ensure that we respond to this what our members are saying, and it is true. You cannot sustain increases that are much higher than MPI as it was the case last year. So it is important that we address this thing, and we are already working hard towards that.
But what's driving the increases? For instance, what drove this 13.4%, which, as we keep reiterating, that it followed at least 2 years of modest increases, and then suddenly, public servants are hit with a 13.4% increase.
It was above budget utilization by our members, and it continues, and we need to resolve it.
Expand on that a bit more. Above budget utilization, does this have to do with the claims that the members are making and the scheme needing to adapt for that?
That is correct. So what happens is that based on these actuarial models that we refer to all the time, it is estimated that, okay, the members spent, let's say, we paid about 60 billion just under 60 billion in 2023. Then they do adjustments based on how our members have aged, what the burden of disease is, so how sick our members are generally, and their behavioral patterns in terms of claiming. Then there are adjustments that are made to say, for next year, you must expect to spend so much. And then only to find that usually is very accurate, within a certain range, 2% out, especially because for us at GEMS, percentage it's huge in quantum. So what we are finding is that our members, despite those proven actuarial models, are utilizing much higher than the estimated, and that is what we have to work on. And it's probably not only appropriate claims, clinically appropriate claims. We've got the element of fraud, waste, and abuse that we also have to overcome. And if we can save on those, then we can bring these claims within levels where the annual adjustments will only be influenced by the things we cannot avoid, like inflation, like a burden of disease, like age.
Sure. Claude, what do you make of that explanation? Above average usage and also in terms of the actuarial model, basically the amount of usage that is there driving the prices higher as far as the explanation goes. Does that wash with you?
My apology, I couldn't hear the doctor at all. But be that may, I can only assume what he had said. Obviously, the usage by public servants, it's something that's unpredictable. There's nothing that we're going to argue about itself. But I think we need to come up with a model that will, one, try and curb the fraud and corruption, as the doctor had indicated previously itself. Usage, you must remember, medical aid is about cross-subsidization. I think one of the things that we need to do is that we have, as indicated in their report, in the annual report, that GEMS has a lot of members that are in the latter years of their career, latter years of their life. So I'm assuming that this is the older age where they tend to use medical aid quite more often. Medical aid is what cross-subsidization. I think one of the things is that the marketing strategy needs to change. In other words, you need to get more younger public servants into the scheme, those that will not be visiting the doctors quite often. And as I said, because it's cross-subsidization, I think this would obviously take care of that. The other issue is that you must remember during COVID, a lot of people, including the general public, as well as public servants, did not attend to health facilities or did not visit health facilities. Simply, they wanted to steer away from the clinics and the hospitals for the fear of contracting COVID. During that time, a lot of medical aids have accumulated reserves. And one would assume that this reserves was obviously to buffer any increases in the subsequent years.
Yeah.
COVID was just a few years ago. So I think that is one of the areas in which GEM should have looked at and say, let's try and oversee this period, this critical period, till we can break even, and then we can consider increases that are slightly above inflation.
Claude, my understanding is that the argument from GEMS is that that has already happened. The usage of the reserves to buffer and cushion the increase on the part of members. My understanding is that that has already happened. Are you saying you've not seen that come through, or is there room to do that even more, even as we talk about, the reserve levels of the scheme coming down quite significantly?
Yes, no, I do understand legislative requirements require medical aids to have a certain amount of reserves in place. We welcome the initiative by GEMS. We're currently busy engaging with them in task teams to see how best we can try and overcome this usage. Look at people that are using service providers that are outside the network, and to educate our members as to what is proper use of medical aid, so that we don't land up with the situation where some people are abusing the situation and others obviously have to pay for that.
Yeah.
Yes, we do welcome that, and we are busy engaging in task teams in that respect.
Final word to you, Dr. Moloabi. Having heard the cry and the call from public service unions, without undertaking and settling a negotiation live on national TV, but what undertaking can you make to try and meet that demand and try and keep the increases to single-digit figures only next year?
Well, just with the preamble, then I answer. The preamble is that we spent already 10 billion to try and help members, as you indicated to last season. So that has bolted already. But we are determined to work, and we engage. We engage with the SABC, which is the bargaining council for all our public sector unions. We engage individually with the PSA, and I'm looking forward to our next meeting with Claude. The main thing is that we are working hard to look at those elements. Those elements involve claims, the level at which our members claim, the claims behavior. Are there people who are just claiming just because they have a medical aid? Are there people who are actually involved in the fraud, waste, and abuse? What about the behavior of the healthcare professionals? There's something from the healthcare market inquiry that was said to be supplier-induced demand. We are working on that to try and say, doctors, you can't just be calling members back to consult, they pay. So all those elements is work that we are doing, and we need our partners, the PSA and other unions, for us to be able to overcome this. But I'm positive.
All right, I thank you both for joining me this afternoon. That's Dr. Stan Moloabi, who is the GEMS Principal Officer, as well as Claude Neka from the Public Servants Association, where he is Acting Deputy General Manager.